Welcome to the Explainer. Today, we're doing a deep dive into Haemophilus influenza. All the information we're going to cover comes straight from a Gemini deep search. And hey, if you want to check out the full source list, it's all in the accompanying notebook document. All right, let's get right into it. This bacterium has a bit of an identity crisis in its history. It was totally and mistakenly blamed for the flu pandemic. That's where it gets its name. But today, wow, it is a massive focus in clinical microbiology for completely different and way more relevant reasons. So here's how we're going to tackle this. We're going to follow a classic bench-to-bedside workflow. We'll start with the real nitty-gritty, the fundamental biology. Then we'll move through diagnostics, what it means for patients, and we'll wrap it all up with a look at public health. Okay, first up, Section 1, a bacterium of two faces. And look, to really get a handle on Haemophilus influenzae, you absolutely have to understand this one core concept first. It defines pretty much everything about its clinical impact. In this slide, it just lays it out perfectly. You've got these two completely different personalities in a single species. On one hand, you have the encapsulated strains. Think of them as the classic invasive villains, like serotype B. Then, on the other side, you've got the non-typeable strains. These are the opportunistic mucosal pathogens. And honestly, they're the big clinical challenge we're facing today. Getting this distinction down is, well, it's crucial for everything we're about to talk about. All right, let's head over to the lab bench and see how this all starts to take shape. We're kicking things off with the foundational identification process. The stuff every microbiologist learns on day one. And here it is, the classic workup. It's just beautiful microbiology, right? It all starts with that gram stain. You see those small, pleomorphic gram-negative cocobacilli, and you know you're on the right track. Then, because this little guy is so picky, so fastidious, it needs that rich chocolate agar to get both its required X and V factors. And of course, the elegant satellitism test on blood agar. You see those tiny colonies just cozying up to a Staphylococcus aureus streak to leach that factor V it needs? It's just a perfect demonstration of its very specific growth requirements. Okay, on to Section 3. Now, those classic methods are great, but for definitive identification in a modern lab, well, we need some more advanced tools. And there's a really, really important reason why. So here's the bottom line. Yeah, classic biochemical tests like the porphyrin test are still solid for confirming that factor X requirement, but the real headache in the lab today, it's telling the difference between the pathogenic non-typeable Haemophilus influenzae and its look-alike, the often harmless commensal Haemophilus hemolyticus. They can look so similar, and that's exactly where molecular methods become non-negotiable. Real-time PCR is the gold standard now, not just for figuring out the capsular type, but for zeroing in on specific genes like HPD, the one for protein D, to be absolutely sure we've got the right culprit. Okay, Section 4. This is where we bridge the gap. We're connecting all that lab work directly to the patient. We'll look at the diseases this bug causes, and then we'll get into the super interesting differences in how treatment is approached in different parts of the world. This slide really nails the clinical spectrum. It shows you exactly how the bug's biology, is it encapsulated or not, translates directly into a different disease profile for different people. The encapsulated forms, they cause those terrifying, severe invasive diseases, like meningitis in kids. Meanwhile, the non-typeable strains are the workhorses of mucosal infections, a huge cause of otitis media in children. And this is critical, a major trigger for COPD flare-ups in adults. So let's take a look at the Dutch guidelines for adults coming from SWAB, which is their working party on antibiotic policy. Now, you can see the specific recommendations here for things like meningitis, CAP, and COPD, but what really jumps out at you is the heavy emphasis on antimicrobial stewardship. I mean, look at meningitis. They recommend de-escalating from ceftriaxone down to amoxicillin if the bug turns out to be susceptible. That's a really proactive approach. Now, for kids with acute otitis media, the Dutch approach is, well, it's pretty conservative, and that's putting it mildly. These guidelines are from the Dutch College of General Practitioners, or NHG, and their #1 recommendation? Watchful waiting. Basically, hold off on antibiotics, manage the pain, and just observe for a couple of days in most cases. It's all about minimizing antibiotic exposure. If they do need antibiotics, the first choice is just a standard dose of amoxicillin. And this slide, this is a tale of two philosophies, for sure. On the left, you've got the Dutch approach. It's very population-focused, right? The goal is to reduce overall antibiotic pressure in the community. On the right,
You have the American Academy of Pediatrics approach, the AAP. This one is much more focused on the individual patient. The goal here is to maximize the clinical benefit for that one child, which means recommending antibiotics right away for severe cases and often using higher doses. It's just a fascinating contrast in stewardship strategy for one of the most common childhood infections on the planet.
All right, let's pivot to a really critical topic, antimicrobial resistance. We're going to look at how standardized testing helps guide effective therapy, because this is where the lab plays such a massive role in patient outcomes. So, it's super important to get this. Resistance in Haemophilus influenzae is not a one-size-fits-all deal. It's really driven by two totally different mechanisms. The most common one is beta-lactamase production. The bug makes an enzyme that just chews up ampicillin. This can be stopped by inhibitors like clavulinate. But, and this is a big but, we're seeing more and more resistance from alterations in penicillin-binding protein 3, or PBP3. And that, my friends, is a whole different ballgame. And that brings us to this specific phenotype, BLNAR. It stands for beta-lactamase negative, ampicillin resistant. You absolutely have to know this term. This is the one where resistance is coming only from those mutations in PBP3. The beta-lactamase test will be negative, but the bug is still resistant to ampicillin. This workflow from EUCAST is just so smart, so elegant. It gives labs a way to efficiently report a mechanism of resistance, not just a simple S or R. It all starts with a simple benzyl penicillin screen. Big zone, you're probably in the clear. Small zone, okay, time for step 2. You test for beta-lactamase. And that one test tells you everything. Positive, it's enzyme production. Negative, you've got yourself a BLNR. And here are the numbers to back it all up, the specific MIC breakpoints from EUCAST version 14.0 from 2024. Now, here's something really interesting to notice. For a lot of the key drugs, like cefotaxime and meropenem, the susceptible and resistant breakpoints are the same value. What does that mean? It means there's no intermediate category. An isolate gets called one or the other, period. It makes the guidance for clinicians super clear, and it all ties back to that screening workflow we just walked through. All right, for our final section, let's zoom out. We're going to the 30,000-foot view to see how we prevent these infections on a population level and what challenges are still on the horizon. Just look at this number. Over 99%, a greater than 99% reduction in invasive Haemophilus influenzae serotype B disease. I mean, just let that sink in. This is, without a doubt, one of the single greatest public health victories of the 20th century. All of it thanks to the Hib conjugate vaccine. Absolutely incredible. Okay, so what about preventing spread after someone gets sick? That's where post-exposure prophylaxis, or PEP, comes in. But the guidelines are super specific. First, this is only for invasive hive disease, not for the non-typeable strains, and it's not for everyone. It specifically targets households where you have high-risk people, like little kids who aren't fully vaccinated yet or someone who is immunocompromised. And the regimen itself? It's really straightforward. A short, 4-day course of rifampin once a day. The goal is simple but powerful. Wipe out any nasopharyngeal carriage of the bacteria to stop it from spreading to anyone else in the house. And that brings us to the big question for the future. The amazing success we've had against Hib has totally changed the game. It's shifted the entire clinical landscape. So now, the dominant pathogen is non-typeable Haemophilus influenzae. So the question is, what's the next great public health intervention going to be? What will that breakthrough look like for the bug that causes so much mucosal disease today? And that's our deep dive on the very complex, very fascinating world of Haemophilus influenzae. Hey, if you found this explainer useful, do us a favor and subscribe to the channel for more content just like this. And we'd really love to hear your thoughts. What do you think is the next big step for tackling non-typeable strains? Let us know in the comments below. Thanks for watching, and we'll see you in the next one.